Welcome to this explainer. Today, we're jumping right into one of the most intense, high-stakes medical mysteries that plays out every single day in emergency rooms all over the world. We're talking about the rapidly ticking clock of evaluating acute chest pain. You know, you really have to think of the ER physician not just as a doctor, but as a master detective. The second a patient walks through those doors, the medical team has to instantly start gathering clues, cross-examining symptoms, and running high-tech forensics to find a killer that might literally be hiding in plain sight.
So let's dive into this incredible number right here, 6.5 million. I want you to think of this as 6.5 million open case files landing on the desks of our medical detectives every single year, and that's in the United States alone. It's actually the second most common complaint that prompts a trip to the ER, making up about 5% of all non-traumatic emergency visits. That is a massive volume of cases, which means our detectives are facing this relentless, overflowing caseload day in and day out.
But out of those millions of visits, here is where the true mystery lies. The stakes are just incredibly high for the ER team because after all the diagnostic dust settles, only 5 to 10% of these acute chest pain cases are actually life-threatening acute coronary syndromes, basically a true unfolding heart attack. Finding it is like finding a needle in a haystack. Yet, the pressure to find that needle is immense, and the margin for error, razor thin. If a doctor mistakenly discharges a patient who's actually having a heart attack, that patient's short-term mortality risk literally doubles. It's a terrifying line between a safe discharge and a fatal error. Which brings us to part one of our investigation. More than just pain, the shifting symptoms. To solve this puzzle, the very first thing we have to do is throw out that classic Hollywood myth. You know the one, the dramatic clutching of the chest and the sudden collapse. Our first crucial clue here is the concept of anginal equivalence. Basically, these are subtle but equally dangerous physical signals that indicate the heart muscle is starving for oxygen. Instead of screaming in pain, the heart might just send out distress signals that masquerade as a stomach bug or just exhaustion. So what do these atypical symptoms actually look like? Well, we're talking about pain that radiates up to the jaw, the neck, or the upper back. We're looking at shoulder and arm discomfort, sudden shortness of breath, unexplained nausea or vomiting, breaking out in a cold sweat, or just extreme fatigue. These clues are absolutely critical to recognize because they are far more prevalent in specific groups, namely females, older adults, and individuals with diabetes. If a clinician only looks for that classic elephant sitting on my chest symptom, these high-risk cases could easily slip right under the radar.
Moving on to Section 2, the usual suspects, categorizing the clues.
Now, once those initial symptoms are noted, this is where the patient's exact words become vital testimony. What's really interesting here is how a patient's description maps directly onto a spectrum of suspicion. The specific adjectives they use can literally shift the probability of a heart attack from a deep red, high danger zone all the way down to a green, lower risk zone. It's all based entirely on how they describe what they're feeling. If we directly compare these descriptors side by side, we can really see the detective work in action. A dull central heaviness, a squeezing sensation, or retrosternal tightness, that absolutely screams heart. But on the flip side, if the patient describes the pain as sharp, stabbing, or fleeting, like it only lasts a few seconds, or if it changes when they take a deep breath or move around, well, the clues point away from the heart and towards a different culprit entirely, like a simple muscle strain. Now for Section 3, the 10-minute clock, the race against time. Here is the massive catch for our detectives. Because time is muscle during a cardiac event, this whole initial investigation is bound by a strict, relentlessly ticking clock. Imagine you're the physician. From the exact second that patient arrives at the door, you have precisely 10 minutes. 10 minutes to perform triage, get their vital signs, gather their clinical history, and most importantly, secure a 12-lead ECG. If that readout shows obvious electrical abnormalities, boom, the mystery is solved and the patient is rushed straight to surgery. But what happens when the ECG looks normal, yet the patient is clearly still in danger? That brings us to Section 4, the blood evidence, searching for microscopic damage. When the ECG doesn't immediately reveal the culprit, our detectives can't just close the case. They have to escalate to forensics. The star witness in this phase is high-sensitivity cardiac troponin. This is a highly specific biomarker protein. When heart muscle cells are injured and dying because they lack oxygen, they literally rupture and leak this protein into the bloodstream. It acts as a chemical footprint left behind at the scene of the crime. But here's the tricky part. It actually takes time for this protein to build up to detectable levels in the blood. So, doctors can't just take one sample and call it a day. They have to follow a strict serial testing protocol. They take a baseline test at hour 0 and then methodically track the rise and fall of these troponin levels over a 1 to 3 hour window. A rapid rise in troponin, that's the smoking gun of a heart attack in progress.
All of these clues, the history, the ECG, the blood tests, they all feed into this, the clinical decision pathway. Think of it as a literal flowchart of fate. By combining all the evidence, doctors can objectively score a patient's risk. This brilliantly illustrates how they can confidently and safely rule out a heart attack in low-risk patients, or catch an unfolding crisis in those tricky intermediate-risk patients who need much closer observation.
Finally, we reach section 5, choosing the right test, the high-tech finale. Sometimes, even after all that evidence is gathered, a patient is still left in a diagnostic gray area. The clues are just inconclusive. That requires doctors to escalate the investigation one last time to advanced, non-invasive imaging. Today, they can use incredible tools like coronary computed tomography angiography, or CCTA, alongside digital blood flow modeling. They can actually digitally reconstruct the patient's heart in 3D to visually pinpoint exactly where blood flow is restricted.
The power of this technology is an absolute game changer. Not only does it have incredibly high diagnostic accuracy, but it doesn't even require the patient to run on a treadmill. Plus, it evaluates the total plaque burden in the arteries, making it highly preferred for patients under 65. It's a stunning resolution to our detective story because it allows doctors not just to rule out an immediate heart attack today, but to spot early plaque buildup and intervene before a heart attack ever happens tomorrow.
So, what does this all mean for us? Well, the crucial takeaway is this. While doctors are absolutely incredible medical detectives armed with amazing technology, they cannot save your life if you ignore the subtle clues your own body is leaving. Whether it's sudden central pressure or an anginal equivalent like unexplained jaw pain or extreme fatigue, would you recognize the clues? Understanding this isn't just about knowing how the works, it's about knowing when you need to walk through those doors and let the detectives do their job. Thanks for joining me on this explainer, and stay curious.